Candidate 1, are you with us?
Yes, sir. Can you hear me?
Just bear with me. I think maybe the can the co-host hear me?
Yes.
Yeah.
Yes, Dr. Khan.
Right. So, candidate 1, mm,
Can you hear me, sir?
yeah, I can hear you. This is candidate
Yeah.
1.
Yeah. Yes.
Okay. Thank you. Sorry for a bit of late start. So, today, of course, is a same old pattern. So, let's crack on. Each candidate is going to get 3 cases, just like the previous pattern. So let's start. Right. So candidate 1, this is your first case. Can you see the case?
Yeah.
This is a 74-year-old male came with shortness of breath, hemoptysis, loss of weight, dysphagia. So over to you.
Okay. So this is the frontal chest X-ray of a female patient who has hemoptysis, the shortness of breath, and dysphagia. I can see that there are multiple focal opacities scattered throughout the both lung fields. There are some there's a feeling of the left hemidiaphragm, suggestive of basal atelectasis. I can't detect any pneumothorax. The heart size and mediastinum appear within normal limits. I'm checking the bones. There is no obvious abnormality. Uh, um, no pleural effusions. Um, uh, the left hello. The left breast shadow is I think both breast shadows are seen. So in summary, in a patient with dysphagia and hemoptysis, my first possibility is with multiple opacities is metastatic lung deposits. And given the patient has dysphagia, I might consider that the patient might have esophageal neoplasm. The second possibility is metastasis from any other malignancy. The third possibility is maybe maybe foci from septic emboli. So my next step is I will alert the referring physician and request CT, chest, abdomen, and pelvis with contrast, and I will suggest discussion in MDT, lung MDT.
Right. Any signs of the primary on this pill? Look
I
at the
think
trachea. Anything abnormal in the trachea?
yeah, there's some narrowing in the trachea. I have noticed it in the upper trachea. It looks slit-like. So there might be a mass in the upper neck, mediastinum. So I'm again concerned about the esophageal neoplasm.
How will it cause tracheal narrowing, esophageal neoplasm?
It will cause a deviation more than narrowing. Maybe a tracheal neoplasm, one of the possibilities.
Mm-hmm. So regarding the left lower lobe, you are worried about atelectasis there.
Yeah.
So what has happened? Why don't you see the diaphragm?
It might be because of lower lobe small consolidation or atelectasis.
Do you see any further evidence of lower lobe atelectasis?
So the mediastinum is not shifted. I think it's central.
That's fine. You wanted to see a CT scan, isn't it?
A CT, yes, yeah.
So here you are. This is a CT scan. Over to you.
So can I request
You can
control?
ask for the mouse control. I have approved it.
Okay. Sorry, it's not scrolling. I'm trying. Yeah, I'll scroll from here. Okay. So this is the CT chest, axial cuts, lung window. I will go through the cuts, the whole sets of the cuts, and then I will compare my findings. Okay.
So what have you picked up?
So I picked up a tracheal trachea endotracheal lesion. Yeah, here.
Mhm.
Um, and I confirmed that the multiple metastatic lung deposits, most probably they will be metastatic.
Mhm.
So there is a polypoidal a soft tissue lesion within the trachea. So my first possibility will, and there is a lower lobe consolidation. I would like to check both bronchi. Okay, so there is no obstructive mass in the lower lower left lobe trachea. Sorry, left lower lobe bronchus. I'm trying to scroll, but it's not.
That's fine.
So my first, yeah.
so
So my first possibility. Sorry.
yeah, please continue.
Yeah. So again, my first concern will be an endotracheal malignant lesion with multiple bilateral pulmonary metastatic deposits, and lower lobe consolidation. So
Okay, thank you.
yeah, thank you.
So this is the first case, and this case is a carcinoma esophagus with secondary invasion of the trachea, metastasis to the lung, metastasis in the mediastinal nodes, left lower lobe collapse. So let me give you a feedback right now. You did not ask for more windows. Candidate one. You see,
Yes.
you have to ask the
Yeah.
and that was a big, should I say, mistake. You should have asked, and you might have picked up the finding, which you had picked up everything very well, actually. So, and you should have asked for a mediastinal window, and then you can say that I want to see the bone window, or you can say that I want to, in my routine practice, I'll see the bone window, because you don't know if there are metastases in the bone also.
Yeah.
But
Bonus.
your main feedback for you is windows. Now, I'll show you the case later on, but basically there is a so trachea. Now, the point is that when we look for a chest X-ray, our protocol is that we must look at the trachea. And so here there was a finding in the trachea. And so this is from your book, 5.1 tracheal or bronchial narrowing. And there is a huge differential diagnosis. But the point is that any mediastinal mass, primary tumors, retrosternal goiter, etc., can cause narrowing. When you see irregular narrowing, then that's an evidence that there might be some direct invasion of the trachea. Carcinoma esophagus, on a CT scan, we know that the investigation of choice for local staging is a EUS, but many a times EUS cannot be performed because of tight stricture. So you have to know the T4 lesion criterias for on CT scan. So CT is quite good. It might not be perfect, but it is quite good. In this particular case, it was blatant. So please remember that for a T4 lesion, actually this is a what we call a T4B lesion. Uh, when it is an unresectable tumor, and it will go into or involve structures like aorta, vertebral body, trachea, etc. Regarding lymph nodes, please remember the concept that regional lymph nodes are lymph nodes, but non-regional lymph nodes are considered metastases. So in this particular case, once we see the mediastinal window, we will see that there are lymph nodes even below in the mediastinum, not at the level of the tumor. So these will also be regarded as metastases. Last time I showed you a case about esophageal carcinomas, T4 criteria for CT signs of incurable disease. So as far as trachea is concerned, usually this is the upper trachea. We are just distal to the level of the thyroid here. And we can see that this is the trachea, this is the esophagus. Usually the posterior wall of the trachea is flat, and there can be subtle indentation of the esophagus. So don't call it. CT criteria is that if you see significant indentation, particularly anterior displacement of the trachea, or you see a luminal mass, or of course you might see irregularity of the lumen, then you call it. It's a big finding because we know that no surgery can be done then. Last time we did cover other signs of T4 lesions, which include involvement of the left main bronchus. And I think in the current exam, people got a case of left main bronchus involvement by the esophagus, and which there was a fistula there, which could be confirmed on a contrast solo examination. So these types of findings are important. And I also told you that encasement of the thoracic aorta, what is the criteria? What is the criteria? So the criteria to for if the left atrium is indented, this is taken as a potential sign of pericardial invasion. If there is no fat plane between, please remember we are not very, very good there on, but once you see it, you can call it. Everybody knows that the sensitivity of EUS is much better. As far as the descending aorta is concerned, so as far as esophagus is concerned, four things you must remember where we can pick up signs of inoperability. One is the trachea, second is the left main bronchus, then is the descending aorta, and then is the pericardium. By the way, if the pericardium is involved, it will still be a T4, but they can still do surgery if other factors are fine. So if you see this, the contact between the tumor and the esophagus, and the criteria is that if the contact with the descending aorta is less than 45 degree, it is not involved. If it is between 45 and 90 degree, then doubtful. More than 90 degree, it is probable. If you see here, look at this contact. So if I draw a line imaginary from here to here, this is 90. This is much more than 90. This is involved. Another very important sign is this one, when there is obliteration of fat. So normally, this is the thoracic aorta, descending aorta. This is the vertebra, and there should be fat in between these, a triangular fat. If this fat is obliterated by soft tissue, this is taken as a good sign of invasion of the thoracic aorta. Sensitivity is 100%, specificity is 82%. Regarding coming back to trachea, please remember when we teach chest X-ray, when we learn chest X-ray, we always say that in a chest X-ray, you have to look at the position, the outline, and paratracheal stripe. So this is the trachea, and it naturally deviates slightly to the right side. This is normal position. And then look at the outline. And in our case, the outline was not normal. So the key feedback will be to keep, your basics and keep looking at things. So I'm not going to go into details of paratracheal stripe, etc., but I'm sure all of you know that. My main idea was that trachea, never forget the trachea, that's the learning point here. This is a case of goiter where we can see that there is a bit of narrowing and there is displacement, but there appears to be a soft tissue mass here in the neck. So this is goiter. Trachea, whenever there is a pneumothorax, this is a tension pneumothorax. The trachea is deviated, displaced to the contralateral side. On the other hand, in this particular case, there is upper lobe collapse because of fibrosis, and that's why there is loss of volume and trachea is deviated to the ipsilateral side. In this one, trachea is deviated to the contralateral side. Here it is the ipsilateral side. Right. So now let's go quickly to the case. So everything else you picked up very well. Uh, there are metastases which are obvious metastases. Uh, if you see the left hemidiaphragm, it is not visible. So there is left lower lobe collapse, which was very well picked up. I just wanted to highlight that if you see carefully, this is the left ventricle, and you can see something extra there. You know, even here, there are signs that this might be not a complete collapse. It is not an absolute complete collapse. Please remember the sale sign where in an absolute complete collapse, this thing sits somewhere here, right? It has not become, so there must be a bit of air inside. So it is close to a complete collapse of left lower lobe. This was well picked up, but this is the finding where we can see this is the trachea, and then you can see something luminal narrowing. There is a soft tissue indirectly inside. Here, candidate did well, picked up the finding very well, described this, but forgot to ask for windows, which would have enabled the candidate to describe, the findings. Again, it was well, there was an attempt to see if the lower lobe bronchus is obliterated. Actually, if you look carefully, this is the right side, and you can see that this is the right lower lobe bronchus. Here it is here it is obliterated, and means it is invaded by lymph nodes, etc. Now we go to the mediastinal window. And on mediastinal window, we can see what we wanted to see. So this is the thyroid, this is the trachea. As we come slightly inferiorly, we can see this thickening surrounding the esophagus, and this is the mass which goes into the lumen. So you can infer that there is esophageal malignancy. With esophageal malignancy, there are lymph nodes. Now, look, these are subcarinal lymph nodes. So these are non-regional lymph nodes. And there are lymph nodes here actually which are compressing the left main bronchus. So the point is that these are non-regional lymph nodes and they will be considered as metastasis. Right. Thank you, candidate one. So the main feedback is ask for windows. Okay. Now,
Yeah,
next
sure.
case. Next case is 27-year-old female had a ultrasound uh, which picked up a unusual pelvic mass. They could not decipher. They asked for an MR.
Okay. So this is I'm sorry, I can't scroll. Should I ask again
Yeah.
for control? Okay. This
So
is T2
Hmm.
T2 axial images of the pelvis. MRI pelvis of a female, a 27 years old female patient with pelvic mass detected in ultrasound. I'm going through the cuts. So I'll try to scroll till the end of this set. Okay, so there is right adnexal, large right adnexal hypointense lesion, indenting the and shifting the uterus to the left side. I'm trying to check if it's continuous with ovary, right ovary. Okay, and I couldn't see the ovary separate. I think it's within the ovary. There are some follicles here. Okay. And okay, and there is another there seems to be the another lesion on the right adnexa with thick wall and hypointense content. So I'm trying to locate the left ovary. I can't see the left ovary actually. Separate.
So till now, what is your conclusion? Till now.
There is a right adnexal lesion.
Okay. Would you like to see anything else?
Yeah, I'd like to see coronal image. Okay, so this is coronal T2 image. Coronal T2 6. Sorry, I can't scroll. Yeah. Okay. So it's not scrolling. I'm sorry, it's not scrolling.
If you hold the yeah.
Yeah. Okay. So I have to use this. Yeah. Okay. So this is the blood here. Again, there is a thick-walled cavity on the right side with hypointense contents. I think it's continuous with the uterus. It might be duplicate anatomy. I'm just trying to check if it's communicating with the cervix. And the right, okay, so this is the right ovarian lesion, hypointense lesion. So I'm just trying to identify the left ovary. It's not scrolling again. So yeah.
You want to say anything else?
I would like to see the T1. T1.
Leave the mouse. Leave the mouse.
Okay. Okay.
This is a T1.
Okay. It's not scrolling again. Sorry.
So I'll scroll for you. Leave it. I'm going to.
Yeah, please. Okay. 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 So this is the T1 axial section of the pelvis. Okay. I can see that the right nixal cyst is shows hyper intense signal, which I would like to confirm on fat suppressed images to rule out that it's blood.
What
Fat.
kind of a sequence is this? This is fat suppressed sequence.
This is fat sat. Sorry. So this is fat sat. I'm sorry, and so it's a hyper intense, which indicates that it's blood content.
Okay, I want you to give me the answer now. What it is?
Okay.
Just
So
conclude
it's
it.
most probably it's right ovarian endometrioma.
Okay, thank you. Thank you.
Okay.
Let me give the option to in the chat, the audience. Anybody got the diagnosis? You can share your diagnosis, then I'll show you the case. Excellent. Some of you got it correct. That's fine. So let me go through it.
So yeah.
So this case is uterus diadelphes with hematocolpus. Hematocolpus means the blood is in the vagina. This was vaginal blood which you were seeing. And hematometra means when it is in the endometrial cavity. Sometimes there can be both. And in this case also you will see a bit of blood in the endometrial cavity also, but basically it is a hematocolpus. So this is a uterus diadelphes. What is uterus diadelphes? It is complete duplication of uterine horns as well as duplication of the cervix. So please remember, complete duplication of uterine horns as well as this thing. Just 1 second. Right. So as well as the cervix, there is no communication between the two. So this is from Radiopedia, where you will see this is how they have made it, that right-sided cavity, left-sided cavity, the cervix is there. They have shown a connection between the two, but other references have given this kind of pictures also where there is no connection between the cervix, right and left cervix. Having said that, that doesn't matter. Key point is that there is no communication between the cavities. And you can see that this is in continuity with the vagina. Key point to remember is that whenever you see it, you have to ask the examiner that I want to look at the kidneys. And because it is associated with renal agenesis, Second point to remember is that usually there is a vaginal septum. And when there is a vaginal septum, there can be obstruction to one horn. And this is, I've cut and paste this from Radiopedia. So this is obstruction of one horn, which was visible in our case. So there can be septum which can be transverse. There can be septums which are longitudinal. The transverse one will cause this kind of appearance. So basically the same finding on radiology as we have picked up. Now, uterus didelphes, the chances of getting pregnant reduce down to only about 20%. So it is a known case of infertility. And many of the pregnancies which do develop, they also are lost, etc. So always look for a unilateral hydro or hematocolpus if a vaginal septum is present. So this is also a known complication. Now, by the way, the good news is that this patient did manage to get pregnant and was initially struggled and delivered successfully. So that was a success story, and I've got a latest scan. I think this scan is, if I'm not wrong, 2 or 3 years ago. And the latest scan, the hematocolpus is the same, but the patient did manage to deliver with that hematocolpus. So here, what are the points to learn from this case? Of course, the eye see what the mind knows. So this was an axial. So now you can see that there is an endometrial cavity here. There is a junctional zone. And if we trace this endometrial cavity, it is like that radiopedia diagram, as if here they are joined together, but this is the cavity and this is the other cavity. They and they do not communicate. So maybe a fibroid is also there, subserosal type of fibroid. So this is within the vagina. If we go down here, this is the urethra, this is the vagina. So I'm going superiorly. As soon as I start superiorly, there is a hematocolpus. And because of the pressure effects, the anatomy is distorted. The other side is deviated towards the left. And as I've told you, that patient did have a baby subsequently through this cavity. Now, uh, so this is a T2. I think one of the key sequences in gynae imaging is a sagittal T2. For me, this is the most useful. So candidate one, when I gave you an option, I think you should have gone for this. This will show you everything actually. If you see here, this is the uterus first cavity, and then this is that hematocolpus, and this is the second cavity. You can actually see a bit of blood going into the cavity. This was not high signal. I'll show you the T1. And so, and then the ovaries, etc., are visible. Do you see? This is the ovary on the right side, and this is on the left. So T2 sagittal, I think, is best only sequence if you want a choice. So this was a fat set where now you can see that this is the hematocolpus. A bit of blood has gone into the endometrial cavity, but you know that fibroid is visible separate to that. So basically hematocolpus and bit of maybe hematometra is developing. Okay, now candidate one, over to you. Now this case is an A&E case, got admitted through A&E. She is a suspected case of pseudotumor cerebri, what we call intracranial, idiopathic intracranial hypotension, correction, hypertension. So she is being treated for that. Uh, That is a working diagnosis. She has got history of headache. Today she reported with extreme severe headache. So the severity of headache has increased. And so an MR was done. Over to you. She is only 30 years old.
So these are axial flare sequence MRI sequences of the brain. I'm sorry, I have to request again.
Yeah.
So I'm trying to go through the sections. Okay. Okay. It's like I can see that there is. Sorry, I can't move it.
Yeah.
It's
I'll move
stuck.
it. Just leave it. Leave the mouse.
Okay. So I can see that there is bilateral um, um, hyperintensity involving the both thalami and basal ganglia um, uh, extend to the periventricular region. Um, um, so there is no hydrocephalus. Um,
What do you think about
uh,
Holmes? He's a young patient.
Sorry, what do you think about?
The temporal horns, which I am showing you.
Temporal horns, yeah, temporal horns are dilated, which is an early manifestation of hydrocephalus. Um, uh, okay, so okay, and there are some hyper intense foci of the deep white matter as well. Um, I would like to check the sagittal image,
Which
sagittal T1, sagittal T1 or flare. Okay. Okay, so okay. So there is no tonsillar herniation. Um, um, the pituitary gland is normal. Um, um, I can't see any abnormality.
Anything else you want to see?
Um, T2, um, T2
Well,
sagittal. Okay. Okay, so the same areas, the bilateral basal ganglia and thalamus are hyper intense in T2, and there was also dilated temporal horns. Okay. Um, I can't see um, any other abnormality.
anything else you want to see?
Um, the axial,
What do you mean
uh,
axial?
sorry, the sagittal T2.
So I don't have a sagittal CT2.
Um, diffusion, sorry, diffusion images. Okay. So there is hyper intense foci within the left parietal region, frontoparietal.
Okay.
Um, the
Now, what do you think it is?
um, so if the patient has I'm sorry, doctor, I couldn't hear the history well. The patient had hypertension, idiopathic hypertension or hypotension.
They are treating the patient for idiopathic intracranial hypertension. This is their working diagnosis.
Hyper
Hypertension,
hypertension.
also known as pseudotumor cerebri.
Okay. Okay.
Just conclude it because we are running out of time.
Okay. So there is no restricted diffusion within the abnormal areas. It looks like a metabolic or systemic changes. So,
Chat, anybody got it? Yeah, good, good. I think I could see the correct answer as the number one answer in the chat. This is dural venous sinus thrombosis. You see,
okay.
unusual presentation of common condition is one of the headings for this exam. So, and this is one of them. Now, let's revise the anatomy. So, these are the dural sinuses. This is the superior sagittal sinus. This is the inferior sagittal sinus. Here, just concentrate on this part, and this is what this case was about. There are veins here which are known as these two internal cerebral veins. Internal cerebral veins are coming from the thalami as well as the basal ganglia. There are other veins, veins, etc. These join together to form the vein of Galen, and then the inferior sagittal sinus comes here and joins, and then becomes the straight sinus. And this is what this case was about. Now, this is the confluence of sinus, and then the right and the left transverse sinus, the sigmoid, and the internal jugular vein. And here on axial, we can see that these are the internal cerebral veins. That's the take-home point in this case, internal cerebral veins. They are draining, and then they are forming the vein of Galen, ultimately going into the straight sinus. So uh, here, the right and left transverse sinus and the sigmoid internal jugular vein. With that, you have to develop your eyes on cortical veins, and we know that there are cortical veins. You don't have to remember the names, but you should remember the concept, because at times the cortical veins will also be thrombosed with the sinuses. So important for you to remember that concept. So on a CT scan with contrast, these are the internal cerebral veins, and this is the straight sinus here. Now, this is a case from our previous experience teaching files. This case presented to the A&E, actually walked into the A&E, and we can see this is, please remember, this is another presentation which can be shown in the exam. I started from the MR, and because the appearance was, atypical. But this is the same case with, or the similar case, and at times they will start with a non-enhanced CT, where just like a thrombosis of an artery, equivalent of a hyperdense MCA sign or hyperdense basilar artery sign, we can see that the internal cerebral veins are thrombosed, and the straight sinus, and here is the straight sinus, and the vein of Galen are thrombosed. This patient later on became a bit agitated. We attempted an MR, and on this MR, though there is a lot of movement because the patient could not cooperate, but you can practically see none of the sinuses are visible. Now, this is another case where high density in the sinus, here the anatomy is slightly different. If you go to the superior most, this is a non-enhanced CT. So I'm showing you another case here, developing your eyes to pick up sinus thrombosis on a non-enhanced CT where it is high density. And then this is high density, a bit of high density. So this case, then on a CT venogram, we can see this filling defect, and you can see on an axial this filling defect here, and you can see this filling defect on an axial here. So this is the superior sagittal sinus, which is thrombosed. Later on, this patient developed, a bit of cortical hemorrhages. So these are, venous infarcts, which are hemorrhagic. On an MR, uh, on usual sequences, look for loss of flow void. Key thing is, coronal is a very good one, but once you develop your eyes, you can pick up on axial. Here, on this T1 weighted sequence, you can see that there is some high signal here. And you can see that even the cortical vein has got high signal. Please remember that on T1 high signal is time barred because this is methemoglobin. It will take a few days for it to develop like this. A better sequence to see loss of signal void is a T2 weighted sequence, which I'll show you in our own example actually. In this case, you can see this and you can see this high signal here, and you can see on sagittal. And then we gave contrast, and we can see this filling defect. On the MRV study, we can see that the right-sided transverse sinus and internal jugular vein is not seen. You can see this filling defect even here on this sagittal. Then one key thing to remember in your day-to-day reporting also is about hypoplastic transverse sinus. Whenever you see these kind of cases, it is about 16 to 17%. One of the transverse sinus can be hypoplastic. 16 to 17% is a huge number. So a novice will, raise the issue that this is, and it will create lot of anxiety that this is transverse sinus thrombosis. First thing is develop your eyes to see the same sinus on other sequences, particularly 90-degree sequences, axial and then sagittal and then coronal. Is there loss of signal void? On a T1, is there high signal? Rule that out. But another extremely useful tool is CT scan. Please remember that when there is a transverse sinus, so this is the same case, uh, when a transverse sinus is hypoplastic, and I've told you up to 16 to 17% will be hypoplastic. So this is embryological, and the ipsilateral internal jugular vein will also be hypoplastic. And embryologically speaking, the jugular foramen on the left side will be smaller as compared to the right. So always see the CT if the CT is available on your packs. And in this case, we see that on the right side, the jugular foramen is quite big. On the left side, it is small. This increases your confidence of calling it hypoplastic sinus. So I repeat, you have to look for all sequences. On a T2 weighted sequence, look for loss of flow void. Whatever sequences are available, 90-degree sequences, see the sinus is there. On a T1 weighted sequence, look for high signal. It will only be a high signal if the dural venous sinus thrombosis is a few days old. And if there is a hypoplastic sinus on MRV, then look at the CT, and this will increase your confidence. Please also remember to look at the sigmoid notch. This is the sigmoid notch, and the sigmoid notch on the right side, where the large jugular foramen is there, will be more prominent. On the left side, it will be smaller. So this was key tip for day-to-day reporting. This is a case from ACR, similar to the one which I showed you. Here, on a non-CT, we can see the internal cerebral veins. They are high density. Actually, you can now infer that portion of the inferior sagittal sinus vein of Galen is high density. And on MR, look at the signal. This is bilateral thalamus is increase in signal. And bilateral thalamic abnormality is by definition an exam case, right? I'll show you a differential from Chapman. And the caudate nucleus is also involved. In this particular case, so on MRV, in this particular case, you can see that the inferior sagittal sinus, straight sinus is missing because it is thrombosed. Now, in your Chapman, there is a differential diagnosis, bilateral thalamic lesions. I don't have time to go through everything, but please remember that internal cerebral venous infarct is the differential. And in this case, there was, you see, local swelling will be there. And that local swelling is what is causing compression and a bit of hydrocephalus. There is another differential diagnosis in Chapman, which is 13.22, gray matter abnormalities. Again, please remember the definition of gray matter. Gray matter is thalamus as well as the basal ganglia. So thalamus as well as the basal ganglia. And the basal ganglia are caudate plus globus pallidus plus protamina. So again, the venous infarction, as in our case, are there. So let me quickly go through the case.
Taking too much time.
So here, first of all, look at the pattern. So this pattern will be a learning point that this is quite an unique type of, bilateral symmetrical high signal in the thalami, and then bilateral symmetrical in the basal ganglia. These are the caudate nucleus and even the lentiform nucleus. Because of the swelling which is happening there is developing hydrocephalus. Because of that, there is developing hydrocephalus. Usually, you won't see this hydrocephalus. Now, key point will be on this T2 weighted sequence. Here, this is a T2 coronal sequence.
I don't have digital manual.
Please mute yourself.
नहीं सर अब क्लीन कर रहे हैं नो नॉट इन दवाई दवाई हाँ दवाई के सर
So here, the key point says that the abnormality is there. You can see this hydrocephalus, but develop your eyes to look at the superior sagittal sinus. Now, this is the superior sagittal sinus, and you should see a flow void, which should be a black flow void. Here, at places you lose that flow void actually. Where I'm pointing out, this is not a flow void. And it is here, there is, just partial flow void. Develop your eyes to go to the last cut and see it even here. Even here, it is not normal. There is a bit of signal inside it. So this is not, it should be black, as in, absolutely black. So something is happening on this sagittal, and this is actually was visible, but the candidate did not point out that there is high signal here. So a bit of methemoglobin is visible. I did not show you this SWI sequence, but a thrombosed vessel can appear as low signal. So here you can see this low signal, and you can see a cortical vein here and a cortical vein which is also thrombosed. And of course, it will be a difficult call here, but the internal cerebral veins are also thrombosed. So we did not go into this. This is a CT venogram of the same case, and you can see where I'm pointing out there is a filling defect. And you can see that this filling defect goes all the way to the right sinus. And if I show you axials, etc., you will see I've gone to the superior most level. You can see this linear filling defect, and even here the delta sign, and you can see that it goes into the here, even in the sigmoid notch, you can see the filling defect. By the way, I did not show you a CT scan, but this was the CT scan. And by the way, it was missed on this CT scan, but they just advised an MR. But the finding is there, and this is a classical exam case. I could have actually begun with this CT scan, where what you see is that you can see this high density, and key finding is, look here, this is the internal cerebral vein, this is the internal, it is high density, it is thrombosed, vein of Galen thrombosed, and it goes here, the dural sinus, sigmoid sinus, the right transverse sinus, it is all thrombosed. You want to confirm it, go to the sagittal and everything is thrombosed. So on the CT scan, everything was visible. Okay, thank you, candidate one. Candidate two, are you with us?
Yes.
Yes, please. This patient is a 76-year-old female, swollen ankle. So she came with a swollen ankle. They said it is warm to touch. They said septic arthritis, question mark, and asked for an ankle X-ray. Over to you.
Okay, this is an X-ray frontal projection X-ray of the right ankle, and I can see there is a soft tissue swelling, and there is a periosteal reaction along both fibula and tibia. This is symmetric, subtle linear periosteal reaction on both sides. So this can be a case of periostitis, or it can be a pachyderma periostosis, or it can be due to hypertrophic osteoarthropathy. Next, I would like to see a chest X-ray or a CT scan to rule out any lung pathology, which can lead to this reaction. This is X-ray frontal projection, and I can see that there is a diffuse opacification at the left lung base. Left CP angle and left hemidiaphragm are not visible, so there is possibility that there is a effusion and a mass or consolidation here. There is slight mediastinal shift to the left as well, also supporting the collapse of subsegmental collapse. Rest of the lungs do not show any lesion. Both the breast shadows are normal, the visualized bones are normal. And next, I would like to see the CT chest to
Anything?
further confirm the finding and to rule out the exact etiology.
So what are the findings in conclusion?
In conclusion, there is a left lower lobe opacification, and this could be a mass, and in this age, this could be a collapse lung with pleural effusion, but in this age, I would like to rule out some neoplastic etiology leading to this consolidation collapse.
Look at the ribs.
Yeah, the ribs are thinned out. There is erosion of first, second, ninth rib.
Mm-hmm.
Ninth posterior rib, eighth and ninth ribs. So this is possibly a neoplastic etiology.
How can you confirm that?
I would like to do a CT chest with contrast.
Before that, can
Um,
ask for, you can change the densities, you can see, you can ask for a magnified view. These things are absolutely critical.
yeah,
You
now I can see a mass.
so okay. So are there, is the rib confirmed or not? The destruction of rib.
Yeah, it is confirmed. Yeah.
So okay. So now, what is your conclusion till now?
So this is a lung mass, and it is causing left lower lobe
You had asked for a.
partial.
I've given you a CT. Over to you. You want to ask for the
Uh,
mark?
yes, I have requested.
Okay, with you.
So this is a CT chest with contrast, and I can see that there's left-sided effusion with the compressive atelectasis of underlying lung, and uh, uh, this looks like a loculated effusion. Um, and this, oh, I don't know, started. Thickening, the fusion is also extending along the mediastinum, and there is nodular thickening of the pleura. So this could be a mesothelioma or a pleural mets.
Anything else?
But this could be a lung mass with the pleural mets. And there is erosion of the rib. I can see posteriorly. There is a mass here posteriorly as well. Um, in between the ribs. Yeah, this is the mass.
So in conclusion,
So this is an extra pulmonary mass. Or this can be a pleural mass with overlying rib erosion, and it is causing pleural effusion with pleural mets and lung compressive atelectasis.
so these are plural mets. This is your conclusion.
Yeah.
Okay, then. Thank you. So actually, you did give us the diagnosis. The fine touch in this case is a bit of description, the findings, etc. I'll tell you when we. But two feedbacks from my side. You, in the chest X-ray, you did not ask for, magnified view, change of density, etc. as far as rib is concerned. And the same thing you did on the CT scan. You were when once you diagnose that there is a bit of erosion, you should have asked for, say that I want to confirm it. So windows you did not ask. So I'll come back to the case. Now, this case is a malignant mesothelioma. Sorry, so the patient has got HOA, which is hypertrophic osteoarthropathy. Candidate did well as far as that aspect is concerned. Asked for a chest X-ray, and this was malignant mesothelioma. With that, there was evidence of loculated enhancing effusion in keeping with empyema. So you did well, but just a bit of fine touch was lacking. Now, uh, just a recap that when you see bilateral, this is the differential diagnosis, bilateral symmetrical periosteal reaction in adults. When you see that, HOA is one of the top ones, and you should have clear-cut concepts that what kinds of pathologies can cause HOA, which there is another differential diagnosis. I'll come back to that, but other than that, vascular insufficiency like varicose veins, etc., can cause this. Thyroid acropathy, which will be basically fingers. Pachydermoperiostosis is, these will be in teenagers. This is known as primary HOA. And then fluorosis, etc., is, interosseous membranes of radius and ulna. Hypervitaminoses A in very rare. So this concept is critical for you, and one point here can save you a long case or a viva case in the exam. Hypertrophic osteoarthropathy, one is, look at the headings, primary and secondary. Primary is autosomal dominant inheritance, rare, presents in children and young adults. So this is always in young adults and children. Secondary. Lung cancer is the most common, more than 60%. Other than that, other lung conditions like bronchiectasis, lung metastasis can cause it. Fibroma, mesothelioma, cystic. So they can actually give you a long case or a viva case with any of these. So beware of this. They might give you a cystic fibrosis case with HOA, periosteal reaction. If you don't know this, you are not going to conclude the case. Also, please remember that GI disorders, Whipple's and celiac and inflammatory irritable bowel disease, etc., cyanotic congenital heart diseases, cirrhosis, and look at these ones, lymphoma, nasopharyngeal carcinoma, etc., etc. So this information can cause you or save you a case in the exam, correlating 2 plus 2 makes 4. These are from ACR. This one had HOA, similar to our case, and this one had a lung carcinoma. Another one in femur, there is periosteal reaction with lung carcinoma. This is vascular insufficiency. Actually, the evidence is there if you look carefully, and this is the type of case which can come in your short cases now, the current format, where there are findings. The finding is periosteal reaction. And then there is evidence that what is the cause. This is a dilated vein, partially calcified. So one can infer that this is the vascular cause of periosteal reaction. This is a 19-year-old with pachydermoperiostosis, what we call primary HOA. Age is the key here. And these, the small bones of the hand, for example, the metacarpals, they are involved, and radius, ulna, tibia, fibula, all of these can be involved, and there is a bit of literature and pattern on it, which I don't want to go into details of that. As far as mesothelioma is concerned, it is an aggressive malignant tumor. 90% of them arise in the pleura, but there is a concept of peritoneal mesothelioma, pericardial mesothelioma. This cystic multicystic mesothelioma actually occurs in the pelvis. Tunica vaginalis testis mesothelioma. So these are rare, but and the prognosis is not very good. Rather, it is quite bad, mesothelioma. So asbestos exposure is seen in most of the cases, 40 to 80% of them. Anybody who has got asbestosis exposure, there is a lifetime risk of 10%. There can be a latent period of 20 to 35 years before the patient develops mesothelioma. And there is no convincing evidence of association or with smoking. So remember that. Now, there were some findings here which I want you to develop your eyes on this. There was a, on CT scan, pleural mass, nodular thinking, soft tissue attenuation. Now, soft tissue attenuation, what I am telling you right now, just remember in your mind, I'm giving you Hounsfield unit. I should have put it in the slide here, but usually soft tissue density is like, let's say, muscle density. So it will be anywhere between 30 Hounsfield to 70 Hounsfield. Simple pleural effusion will be less than 10 Hounsfield. It will be like water. And slightly turbid, maybe a bit of protein content or a bit of hemorrhage, it will be up to 30 Hounsfield. So soft tissue attenuation will be 30 to 70. And you can ask the examiner that I want to measure the density. So you have to remember it like this. Now, actually, the candidate pointed out this thing very well on the chest X-ray. What happens is that there is an inward contraction of the hemithorax. So there is loss of volume and there is ipsilateral mediastinal shift. So the candidate actually pointed out on the chest X-ray that I'm worried about that there might be collapse because there is an ipsilateral, but that is actually a finding when you get this pleural thickening like this. Pattern of spread, eventually it grows and it can encase whole of the lung, what we call the pleural rind. And local invasion, you have to get marks, you have to point out local invasion. In our case, there was involvement of the bone, but there is more than that because the pericardium was involved in our case. I'll show you. And if you see here, known to invade even along catheter and biopsy tracks. So please remember, if a tube has been passed, the lesion might grow into that. If there is pericardium, may represent transpericardial extension. Now, calcification can be seen in 20%, but usually this calcification is the pleural plaques which get engulfed in it. But there are other variants in which there can be calcification. So let's go through the case. Now, so we can see this periosteal reaction, periosteal reaction, periosteal reaction, and reaction here. Then the candidate asked for a chest X-ray, which was good. On this chest X-ray, we can see this opacity. Actually, this was pointed out that there is loss of volume here and there is subtle shift of mediastinum to this side, ipsilateral shift. And then this is the rib destruction. So something malignant is happening. Now, if we go to the CT scan, so what is happening on the CT scan? Now, if we go to we are close to the diaphragm. Actually, the feedback is that whenever you describe a thing and you ask the examiner that I want to see a sagittal, I want to see a coronal to see that. Now, this is the spleen. As we go to the diaphragm, it is thickened. And if you look carefully, what is happening? There is this nodular pleural thickening. Look here, where I'm pointing out. There is nodular pleural thickening here. And there is nodular pleural thickening here also. Now, just superior to that, where here, what is happening, that there is a bit of loculated empyema, which is enhancing, because pleural effusion is part of the spectrum of it, but this one has got infected. So with that, there is a bit of empyema, a bit of consolidation. But then look at this. This pleural thickening is going and encasing the aorta. Now here, what it is doing, it is what happened? Is my can you see the screen, or for me,
No, we cannot see your screen. Yeah, now we can see.
Okay. So, so if you look carefully, now this is the fine touch to get marks. Now, if you see here, it is going along. Now, this is the pericardium. So there is pleural thickening here, and this is pleural thickening. Here, there is loss of any fat plane, and we would like to confirm it, but you can say that I'm worried that it is invading the pericardium. Even here, there is a rhine going along superiorly. So, and it goes along. It can totally encase whole of the lung, and that is why there can be loss of volume. So if you see here where I'm pointing out, you can see this tissue here, how it is going beyond the rib cage and going into the soft tissues here. And of course, it will cause rib destruction, which here the point is that ask for a bone window where I'm pointing out there is destruction. So just to highlight on a sagittal, just concentrate on the diaphragm, and you can see, look at this thickening where I'm pointing out the diaphragmatic pleura. There is a mass there, and this is that empyema I was talking about. And look at this, how it is causing destruction. And as far as the pericardium is concerned, let me show you a coronal. Here you are. So this is the left ventricle, right? And as we go here, the fat plane is lost. And here, where I'm pointing out, actually, you can convince yourself that the pericardium is invaded. So this is a bit of fine touch about the case. Okay, thank you, candidate two. That was actually well done, but just a bit of fine touch was lacking. Okay, now this patient, candidate two,
Yes.
is the 36-year-old female, history of menorrhagia, dyspareunia, and abdominal pain. On palpation, they say that there is a mass question mark in the on the left side. They have done an MR. Over to you.
Sorry,
Okay,
it's
leave
scrolling
it.
very fast.
Just leave it. I'll do it for you.
Okay.
So, uh,
So this is a MRI of the pelvis, axial T2 image, and I can see uterus appears a bit bulky, and there is a well-defined cystic lesion in the left adnexa, and it shows it is hypo-intense on T2 weighted image. Can I see the sagittal?
tell me the findings on this one.
Okay, so there's a hemorrhagic cyst, and there is bulky uterus. So this could be an endometriotic cyst.
What else do you see?
And also the uterus is bulky with thickening of the junctional zone posteriorly. So this could be an adenomyosis. And also I can see tethering posteriorly with the sigmoid colon.
So, what is this?
This is an endometriotic cyst, most likely.
How will you confirm it?
I want to see a T1.
Okay, this was high on T1.
So this confirms the hemorrhagic content.
Right. What is this where I'm pointing out?
Uh, is this bladder? Okay, bladder is separate. So this can be another lesion, which is
So you asked for a T2, and now I'm giving you a T2 sagittal.
okay. So on T2 sagittal, I can see that again, I can see that the uterus is bulky with a tethering with posteriorly with the sigmoid colon, and there is a large fluid density intensity lesion with loculus with a hemorrhagic cystic component.
So how do
Can
you,
I see? Yeah, sorry.
what do you want me to show you?
Can I see the coronal view?
Coronal view.
Yeah. Okay, again, this is coronal T2, and I can see that again, I can see the same findings. Can I see T1? So I just want to see the signal intensity of this big lesion on T1. So it is hypointense on T1. So this looks like a peritoneal inclusion cyst.
Peritoneal inclusion cyst. So overall, what is your conclusion?
Overall, I think this is a case of endometriosis. There is adenomyosis, there is a chocolate cyst, and there is tethering of the uterus posteriorly with the colon at one point.
And what is this?
And this looks like a peritoneal inclusion cyst.
What is a peritoneal inclusion cyst?
After surgery, basically they are thin-walled and
How do they develop?
basically they develop after some kind of intervention or surgery, and
Why do they develop?
because of adhesions, maybe.
Okay, thank you. So your diagnosis was absolutely spot on. This is deep pelvic endometriosis with adenomyosis. We also saw an endometrioma, and there was a peritoneal inclusion cyst. Now, peritoneal inclusion cyst, what are these? These are also known as peritoneal pseudocyst, and they appear in relation to the peritoneal surfaces, result from a non-neoplastic reactive mesothelial proliferation. Non-neoplastic reactive mesothelial proliferation. So, what happens is that associations, as the candidate pointed out, previous surgery, abdominal, but what I wanted to highlight is that you can see them with endometriosis. And previous inflammatory bowel disease, previous abdominal surgery, pelvic inflammatory disease, but also with endometriosis. And key point to remember is that they can present with pelvic mass, and when they palpate the patient, they might actually think that there is a pelvic mass, and this is exactly what had happened in the case which I told you. Though it's an incidental finding, but what is the pathology? The pathology is important for you to remember because these kinds of questions are asked, and this is what I asked the candidate. This is caused by accumulation of ovarian fluid that is contained by a peritoneal adhesion. Normally, what happens is that this fluid is produced, but normal peritoneum absorbs the fluid easily. However, when it is abnormal, it does not absorb, and that is how it is produced. they can actually be very, very big. They can be, big, bulky. They can present like this. They can entire, abdominal cavity, pelvis, and abdomen can be involved. As far as radiological appearance is concerned, uh, location of the ovary with respect to the cyst is clearly demonstrated on MR, and try to highlight that and try to see that. These are cases from Radiopedia where we can see one of them here. This is the ovary. So relationship with ovary is a key finding. And now I will go through the case. And so this was well done because the candidate picked up everything. Uh, uh, Now, if you see here on this T2-weighted sequence, this is that endometrioma on this axial. We can see that there is tethering. Develop your eyes because at times they will just show you one sequence, which might be an axial, because you can see the sigmoid colon tethered to the posterior surface of the uterus. And there are some plaques of endometriosis which are adherent on the posterior serosal surface. And so we can see this tethering even going here. And on T2-weighted sequence, we can see the same finding. Here you are. Look at this. So around that endometrioma, you can see that, of course, there was adenomyosis. Normal junctional zone should be up to 12 millimeter. This one is much more than that. Tethering is present here, and tethering is present on the other side. Candidate did well, asked for a T1 weighted sequence, which was good, and this was endometrioma, and the cyst, of course, is cystic. So I wanted to show you this case because of the peritoneal inclusion cyst. And this is what the exam is about, unusual presentation of a common finding. So whenever you pick up endometriosis, look for associated endometrioma, any adenomyosis, and I've shown you additional finding today of an inclusion cyst. Candidate 2, 20-year-old male, left hip pain.
Okay, this is an X-ray frontal projection of pelvis and including both hip joints and lower spine of a 20-year-old male who presented with left hip pain, and I can see that there is a lytic expansile, a loosened lytic expansile lesion involving the ischium, left ischium, and it appears to have a narrow zone of transition. My differentials would be, this could be a fibrous dysplasia, this could be an aneurysmal bone cyst. Looks like a non-aggressive lesion. Next, I would like to do a CT for this patient.
CT.
Or maybe an MR. Okay. So.
Call it for you.
Okay, thank you. So this is T2 fat set, and I can see the same lesion, and there are multiple fluid levels in it. So this is most likely an aneurysmal bone cyst.
What will you do?
I would refer this patient to the orthopedic department for further management.
What is your differential in this case?
This can be the fluid levels can be in aneurysmal bone cyst, in GCT, in telangiectatic osteosarcomas, but this looks like a non-aggressive lesion, and the age is also young. So the topmost would be aneurysmal bone cyst.
Okay, thank you. This was aneurysmal bone cyst. Now, aneurysmal bone cyst, the age group is young age group, usually children, 5 to 30. Most of them will be less than 20 years actually. Location in a long bone is metaphyseal. They will be eccentric. They will be lucent, uh, and margin can be well defined. They will be expansile. Please also remember the concept that they can occur secondary to other lesions. They can occur secondary to other lesions. So these are, this is in femur, this is in humerus, another one in humerus, another one in humerus. Do not forget, short bones, small bones of hands and feet. So they can be practically anywhere. They can also be in the spine. Now, uh, fluid levels, if the lesion has got more than 75% fluid levels or more than that, you can be very confident in calling it in aneurysmal bone cyst. So this one on MR is fluid level. So candidate, the feedback for you is CT. To ask for a CT is a big blunder. You don't characterize bone tumors. There is no role of CT, other than in your FRCR. The only thing in which you can ask for a CT is an osteoid osteoma, where osteoid osteoma, the nidus versus a fracture, stress fracture, let's say in a long bone. Otherwise, go for an MR. So other than plain films, go for MR. So, and CT will not help you. CT can be done as a, as a problem solving tool or for planning, etc., etc. I'm not saying they don't do CTs, but for characterization, that is MR. So for your exam, the principle is in bone tumors, except for osteoid osteoma, ask for MR. Now, this is another aneurysmal bone cyst, which is eccentric, which is metaphyseal, and again, the diagnosis is confirmed on the fluid levels. And so, fluid levels in bone lesions uh, on MR, of course, MR is much more sensitive. Aneurysmal bone cyst, chondroblastoma, giant cell tumor, simple bone cyst, fibrous dysplasia, telangiectatic osteosarcoma. That is a red flag thing in which you can confuse it. Now, in here, an aneurysmal bone cyst is present now this is the CT scan, and you can barely characterize this lesion. You cannot characterize this lesion. So it is arising from the posterior element of the spine. And these fluid levels actually characterize it. Please remember that in the spine, interestingly, an osteoblastoma of the posterior elements can be confused with an aneurysmal bone cyst, because an osteoblastoma, radiologically speaking, can appear as a expansile lucency in the posterior elements of the spine. And there's a bit of fine touch, because there might be a bit of increase, some bone formation which might not be here. But of course, MR will then help you. This is a case of aneurysmal bone cyst, which, other than the posterior elements, has also gone into the vertebral body, and it is causing fluid level. Secondary aneurysmal bone cyst. So aneurysmal bone cyst can occur secondary to other lesions. This is a case of osteoblastoma of the calcaneum. You can see this lucent lesion here in a young 13-year-old. And with that, you can see that there is a bubbly lesion here. This is a secondary ABC. This list should be in your mind. This is secondary ABC. Secondary ABC can occur secondary to GCT, chondroblastoma, osteoblastoma, fibrous dysplasia, non-ossifying fibroma. Some people think after trauma also, and some people think no, they don't agree with this. But in most of the literature, you will see this post-trauma. Now, so this is one thing which I wanted to point out is that lucent epiphyseal bone lesion. All of these things I've covered in our bone section in detail. That look at this location-specific lesions and intraosseous lipoma, calcaneum, simple bone cyst, calcaneum, osteoblastoma, talus. So if you remember this one word here, it will save the day for you in the exam. So at times these informations are so important. There is a lucent lesion in a young age group in the talus, and this lucent, you can also argue, is it an chondroblastoma? But if you know this, you know that osteoblastoma, it is known to occur at this site. Okay, thank you very much, candidate 2. Well done. So next is candidate 3. Oh, sorry. I think I did not show you the fine touch of the case. So let me describe the case. There is no need for the candidate to join back. But if you see here, there is a expansile type of lesion here. Again, you can ask for a, if you see here, you will disregard fibrous dysplasia. It's not ground glass or anything. There appears to be slight bit of septations, expansile. So you will not keep ground glass. Actually, the acetabulum is involved. The posterior pillar of acetabulum is involved. And that is why the patient presented with pain. Now, if you go to it has actually, I think it was not projecting for you. So this is the lesion. And if you blow it up, you can see that it is not ground glass. It is expansile. So ABC was very well done by the candidate. Now, if you see here, look at the anatomy, inferior ramus, and this is the ischial tuberosity. And then if you see the acetabulum, so this is the inferior pillar, and portion of it has gone there. And you could have asked for another, this is a T1 weighted sequence, and on T1 also you can see these fluid levels, hemorrhagic fluid levels. So this was ABC. Okay, candidate 3.
Yes, sir.
This case is a 63-year-old male, known COPD, complains of cough and hemoptysis, rule out malignancy. This was the clinical.
Okay. Okay. Sir, I am provided with a radiograph chest of skeletally mature patient who presented with complaint of COPD, and I could appreciate a soft tissue, an airspace opacification noted in there is volume loss on the left as well, and I'm looking at the ribs. Sir, can you window it slightly? I want to look at the ribs.
So ribs are fine.
Okay, so sir, I'm thinking of a pleural base mass in the left chest, and I would like to go for a CT scan chest of the patient to confirm my findings. On the right, I could appreciate the changes of COPD with hyperexpanded right lung, the flattened hemidiaphragm, and there is this subtle mediastinal shift
No, the mediastinum, I think it's central. So just pleural base mass I'm thinking of. I would like to go for a CT scan just.
Pleural base mass where?
Sir, on the left, upper and the mid zone.
In the mid zone.
Sir, this one. So can you see my mouse?
Just describe it for me. Yes.
Sir, the screen disappeared. Sir, yes, I could see a pleural base mass in the left upper and mid zone with a wide border with the pleura, and I could see the outer margin, and I could not see the outer margin clearly. I could not appreciate any calcification within this mass. Yes, sir. Sir, in addition to that, I think there is some catheter placed over here on the left side.
Look at the.
Sir, I could also appreciate a well-defined opacity behind the medial end of the left clavicle, an apical opacity on the left as well. So, sir, I'm thinking of some intrapulmonary and a pleural mass, and I would like to go for a CT scan. Okay. Sir, should I start stooling?
Yeah.
Okay. Sir, I'm provided with the CT scan of the patient who presented with a complaint of COPD and to rule out malignancy. I could appreciate the lungs are significantly emphysematous. And in addition to that, I could appreciate that there is some cavity with internal soft tissue opacity noted in left upper lobe. Sir, I would like to see it on the soft tissue window. Sir, on the soft tissue window, I could again appreciate this cavity with an underlying soft tissue density, and I could see few scattered calcifications, calcified granulomas as well. So I'm thinking of prior tuberculous cavity with superimposed fungal infection. It doesn't look like a tumor to me, and my primary differential in this is cavity with internal soft tissue likely representing fungal etiology.
What do you mean fungal etiology? This mass.
Aspergilloma.
Aspergilloma. Okay, thank you. So this case is mycetoma or aspergilloma of the lung. There is COPD. There is also incidental pectus excavatum, which was better seen on the CT. Now, what is a mycetoma? It is a fungus ball. This is produced due to colonization of a pre-existing cavity by a fungus. Usually the species is Aspergillus, and that is why it is termed aspergilloma. So basically, pathologically speaking, what is this mass? It consists of tangled hyphae of the fungus plus mucus plus fibrin plus cell debris. So overall, it gives you a soft tissue mass type of an appearance. Please remember that these are considered incidentalomas. They are usually because there is another type of aspergillosis, which is invasive aspergillosis, which is, very fulminant. These are immunocompromised patients. But aspergilloma occurs in uh, immunocompetent patients, and usually it might actually be asymptomatic. So it is a non-invasive form of pulmonary normal immune status, but structurally abnormal lung. Most commonly in cavities of tuberculosis, but can also happen with pulmonary sarcoidosis, bronchiectasis, bronchogenic cyst, pulmonary sequestration, pneumocystis pneumonia. Now, all of this information is key information for you in the exam. Remember, unusual presentation of a finding. So they might show you a sarcoidosis with a cavity, and within that, an aspergilloma might be sitting. So you have to know this. Now, usually they are asymptomatic, but at times, because of surrounding vascularity, there can be hemoptysis. At times, there can be life-threatening hemoptysis. On a plain radiograph, there will be a mass within a cavity, air crescent sign, in which you can see air around it that is quite pathognomic. These aspergillomas can also be mobile, and there can be extended questions. What can you do? How do you confirm? And at times, even doing a follow-up X-ray in another position can confirm it to be a mobile one. And similarly on CT, literature also tells us that some people say that you can do a prone and a supine to see if it is mobile. Having said that, usually these things are not needed, and usually it is quite a confident diagnosis, and in differential nothing comes because of other findings. Sometimes what happens is that the mass, the aspergilloma, so on CT, the air crescent sign, when you see it, you are quite confident. But sometimes what happens is that the mass fills up the entire cavity, and then it will present as a solitary lung nodule or a mass according to the size. So it will become difficult. Uh, Calcification is not uncommon. Treatment and prognosis does not necessarily require treatment. But if hemoptysis is there, you can use, arterial embolization. Sometimes these patients will come with fulminant hemoptysis, and beware of that kind of a case in the exam, where examiner shows you a case in which over this background, the patient has presented with acute hemoptysis and there is hemorrhage, etc. And then the viva will go into an IR type of a thing, and they might show you something from IR world. So these informations are always think like this in to what kind of cases can come from aspergilloma. If it is a classical appearance, there is no differential diagnosis. However, if it fills up the cavity completely, then the differential diagnosis will be of a solitary pulmonary nodule. So this one is sitting posteriorly, just like our case. These are from Radiopedia. This is another one which is sitting here. So let me go through it. So in this case, the pectus excavatum bit on this X-ray is very difficult for the simple reason that though the heart and the right heart border is not very well formed, which is a finding, and these ribs appear more, vertically oriented. These are classical signs of pectus, but counter argument is that because of the rotation, it's very difficult to be confident. So even if you don't pick it up, it's fine. Having said that, you can see COPD, you can see fibrosis. Now here, if you see here, there is a lesion and this lesion, once you pick it up, then you can ask for a magnified view, and here you can convince yourself that this is what it is. So on the plain film, you are quite confident. And then you ask for the CT scan, and so this is the pectus, which I was mentioning, which is a sort of an incidental finding now. And with that, you can see that this is the cavity. Now, the cavity is thin-walled. It is not thick-walled or nodular, because I can ask you these kinds of questions. Are you worried about any malignancy? So you have to say that the cavity is thin-walled. Then there is calcification, which is in a way a good sign here, because it tells you that there is chronic. It is sitting on the posterior surface, but it's not, anything, no stigmata of malignancy. Be very confident in this diagnosis. Okay, next, please. So
Yes.
this is your next case in which what happened was that this is a 77-year-old patient. An ultrasound was performed in the community, picked up a mass in the upper abdomen. They said that it might be an adrenal mass or a pancreatic mass, and they asked for a so that triggered a CT scan, and this CT scan was done with adrenal protocol. Over to you.
Okay. When I'm provided with the CT scan images, first I'll scroll through the entire stack.
Just concentrate on upper abdomen.
Okay, sir. Sir, I'm presented with the CT scan of patient who presented with complaint of mass in upper abdomen, and I'm looking through the images. The first obvious abnormality I could appreciate is a well-defined enhancing mass located in the left suprarenal location. I could not see the adrenal gland separately.
I'll
Okay, sir, the mass is located close to the pancreatic tail, but I'm unable to see the adrenal gland separately. However, I would like to confirm this on the coronal sections. It is showing same enhancement as the splenic parenchyma. I would like to see on other sequences. On the right side, I could appreciate
okay, leave
large.
them
Okay,
out.
sir.
This is another sequence.
Okay,
This,
sir.
because it was done adrenal protocol, so we have got a
Thanks.
non-enhanced 70-second and a 15-minute delay.
Okay, sir. Sir, I'm moving to my area of interest. This mass is again seen, and it is appearing isodense to the splenic parenchyma and is located in the region of pancreatic tail. On the right, yeah. In addition to that, no other abnormal. I could appreciate multiple right renal cysts and calcifications. Sir, can I see it on the on the first arterial phase as well?
There is no arterial phase.
Sir, aren't 3 phases available for the adrenal protocol? Unenhanced. Okay, there's unenhanced arterial venous endolate.
This is the unenhanced.
Okay. So, sir, considering, sir, I would like to just see it on the coronal images. I think I could see the adrenal separately. I'm just want to confirm it.
So, in conclusion,
Sir, I'm thinking of a splenunculus located in the region of pancreatic tail. The mass is neither pancreatic nor adrenal. And I would like to confirm it by doing a sulfur colloid scan, and it will show the uptake over here as the mass is isoenhancing to the splenic parenchyma on all the sequences.
sulfur colloid scan is not available in UK.
Sir, I think in nuclear studies, I think the RBC red blood cell is it available there?
Yeah, something easier.
Yeah, we can do that.
What is that?
Sir, I think it's a nuclear scan in which RBCs are labeled and the spleen and the splenunculus will show the uptake.
Okay, okay, thank you. So this was a simple case, but accessory spleen, right? So please remember that embryologically speaking, supernumerary spleens, accessory spleen, whatever you want to call them, spleenunculus. These days, the trend is that people call it accessory spleen. It is quite a common finding in up to 16% of CTs. Now, sometimes the key thing is to be able to differentiate it from any sinister pathology. And many a times they come for somebody writes that it is because this tissue will enhance equal to the spleen. So if it is next to the pancreas or in the pancreas, because they can be just in the pancreatic parenchyma or around it, people might call it a pinnet or things like that. Key thing is that they are equal on a CT according to the phase, but you don't have to do a nuclear scan. And by the way, sulfur colloid scan, we don't do it in UK. It's not available even. MRI. MRI, it is simple, just on all sequences, and you have got so many sequences on MR. On all sequences, it will be equal to the spleen in signal intensity. So MR will confirm if you are in a doubt. You must know that if a patient has to undergo splenectomy for any autoimmune disorder, etc., then you have to diagnose that there is this accessory spleen sitting somewhere so that they don't leave it. More important case for the exam is splenosis. And my idea was, so I've got good cases of splenosis. In what is the difference between splenosis and spleenunculus or accessory spleen? Spleen,
Sir, I think
accessory spleen is extraperitoneal, and splenosis is intraperitoneal. Splenosis, what happens is the patient had a trauma, had a shattered spleen, and years down the road, there are multiple nodules in the peritoneal cavity, which are now somebody has said that this is in keeping with metastasis. And I have seen cases in which gunshot wound and later on the splenic tissue actually in the posterior mediastinum there was a case in which in posterior mediastinum it just grew up, and actually that is known as splenosis. So it can happen even after splenectomy, particularly after post-trauma or gunshot wounds, etc. So beware about that differentiation. And this splenosis is a more important exam case than accessory spleen. These are the various locations in which they can occur, and they can actually occur in the wall of the bowel. And look at this one, even can occur in the scrotum because of embryology. So just remember it that on MR, it is equal in signal intensity to spleen on all sequences. And that will actually, you will be absolutely confident. This is from Radiopedia, and you can see that there is a large lesion, but it is enhancing equal to the patchy enhancement of the spleen on this late arterial phase. Okay, this patient presented with, this is a 47-year-old presented with headache and fit to A&E. And this is what was visible on the CT scan. Because of time factor, I'm scrolling it for you.
Yes, sir. Sir, I could appreciate peripherally calcified, rounded, central low density lesion located in the right thalamic region. Sir, it could represent some calcified aneurysm of any PCA vessel, and I would like to see the CTA to see it. Otherwise, it could be some calcified lesion, and I would need a CT scan post contrast.
How have you reached a diagnosis of a aneurysm? This is within the thalamus. Anatomy-wise, how can you explain that?
Sir, the rounded configuration and the peripheral calcification, I thought it's just it might be of posterior cerebral artery territory, the secular one, or else it would be a peripherally calcified lesion within the thalamus.
So what kind of a lesion it is? What
Uh,
is it?
Sir, sir, I think it's I could think of some calcified lesion like neurocysticercosis, but they are multiple and they are not like this. Cavernoma. Sir, I'm provided with the flare images, and I could appreciate the lesion that is low on centrally and bright on peripherally. Sir, can I have a T2 sequence? Yeah, so it's cystic and bright on T2. Can I have a diffusion restriction, please?
So the software is actually hanging.
Okay. Could it be some enlarged VR space, but that are not peripherally calcified mostly? Old lacunar infarct could appear like this.
This is DWI.
So it's not showing any diffusion restriction. It's just ISO to the CSF. So can I see post contrast?
This is the post contrast.
Yeah, I think it is showing mild peripheral post contrast enhancement. So I'm thinking of some old lacunar infarct.
But there is a pre-contrast also.
Yes, sir. So it's yeah, it's not showing any significant post contrast enhancement. It's high on T1. Sir, can I have a look at subtraction image to confirm any post contrast enhancement?
What do you mean subscription? For the
T1, as it is bright on T1, peripherally bright on T1.
T1. Why is it bright on T1? Pre-contrast.
Sir, could it represent some hematoma?
Have you seen the CT scan? Was there a hematoma there?
Sir, no, there were peripheral calcifications.
So I can just tell you that there is mild enhancement. This is calcification, which is high on T1, and there is a calcification which will be high on T1. So this is that kind of calcification, and there is subtle, enhancement around it.
Sir, so this is a ring enhancing lesion, and I'm thinking of toxoplasmosis.
What is your conclusion?
Sir, cerebral toxoplasmosis.
Okay. In the chat, anybody? Cavernoma, NCC, dermoid, hydrated, neurocysticercosis. Interestingly, the candidate also said neurocysticercosis, but did not. This is cysticercosis, and it is granular stage of cysticercosis. So this is cysticercosis, and this is granular stage. Let me give you the concept about cysticercosis. Now, this is from Chapman, and cysticercosis is important for your exam. It occurs because of poor tapeworm tinea solium. It can involve soft tissue, it can involve CNS. Now, CNS, you can get cases because it can cause a lot of pathology. A lot of symptoms, should I say. Lesions can be seen in subarachnoid space, in the brain parenchyma and ventricles. So remember that. And there are 4 stages, and you should have clear-cut concept about these stages. There is a vesicular stage where the larva is alive, then the larva dies. When it dies, we call it the colloidal stage. This is early degeneration. Radiologically speaking, this is where the patients will be most symptomatic and they will present with symptoms of seizures, etc. This is early degeneration, and it causes a sort of a inflammatory response, the dying larva. And then there is granular, which is late degeneration. It will start become calcified. It might show some solid enhancement like our case, and there will be variable edema. The edema and enhancement, which will be much more in the colloidal stage. It can even mimic like a meningitis, localized type of meningitis around that. And then it becomes dead, calcified. So you should have absolutely clear-cut ideas. This is just for plain films. Sorry, this is, of course, soft tissue, and this is a differential in your book 4.1, linear and curvilinear soft tissue calcification. Cysticercosis is there. But coming back, look here. In vesicular stage, what happens is, irony is that the larva is actually alive. And it can be seen here. If you look carefully, there will be a cystic lesion with that. We call it a scolex, a mural nodule. Scolex, which is sitting there. This is alive. And then when it dies, this is the early degenerative colloidal stage. It elicits a lot of reaction, and you will no more see this. You will see lot of enhancement around it, and perilesional edema. This is the most common or clinically active stage. But sometimes, like our patient, even can present with granular nodular stage. The difference is that this is more the late degeneration. The parasite is non-viable, so it will start, calcification will start. Progressively, the granulomatous tissue will be replaced by calcification. There can be still milder nodular ring enhancement, and the edema will decrease. And this is what we were seeing in our case. Finally, is the nodular calcified stage, which is this one, where you see innumerable number of calcification. So vesicular stage, look at this one. There will be a nodule. There will be a nodule. On MR, it is sitting in subarachnoid space. This is the colloid stage where you can see this cystic lesion, lot of edema around it. And this is like our case, bit of edema, but not very significant. This is the chronic stage, nodular calcified stage. And in your Chapman, in CNS, I think it is given in 4 differential diagnoses. It can produce hydrocephalus. So beware of a case of hydrocephalus in which, because cysticercosis can be within the ventricles, it can cause hydrocephalus. Beware of that. It is also given in your book in the differential of intracranial calcification, which is common sense because the 4th stage will be calcified neurocysticercosis. It is end-stage quiescent disease. Then it is given, there is another differential diagnosis in your book, intracranial cyst with mural nodule. And of course, cysticercosis is there, early vesicular stage. And then intraventricular mass in an adult, and again, neurocysticercosis is given there. This is another case where we can see this one is viable, and this one has caused edema, etc. So if you see here, this is a cystic lesion. And with cystic lesion, there is a bit of calcification. You cannot say more than that here. This calcification, please remember that lesions which are high in signal intensity on T1, and there is a particular type of calcification which can be high on T1. And this is why, candidate, you should have also asked when you said, I want to see post contrast. Once you picked up that finding, you must ask for pre-contrast. And there was a catch here because the calcification was also high signal. And now a bit of edema is there, just a bit of edema on the flare sequence. And on other sequences, the DWI, etc., you don't pick up. There is CSF intensity in the center of the lesion. If you do an SWI, of course, there will be blooming. And on post contrast, as I've told you, that if you look carefully, there was just a bit of enhancement. So this was what we call this was a granular stage of cysticercosis. Usually, these patients will come to you on earlier stage. And please remember the latent period. A patient can get this stage, can get infected 30 years before, and then can present with this kind of finding. It is very common in particularly Latin America and South America. So then, why is calcification high on T1? There is a type of calcification which is high on T1. It is a particular type of crystal which is high. Key point for you to remember is that you must remember that there is a particular type of calcification which can be high on T1. And I've shown you these cases many times in A to Z, etc. also. Now, last candidate. Thank you, candidate 3. You did very well. Last candidate.
Yes, good evening, sir.
Okay, so we have got a case from and it is a CTPA. What happened was that this was a 44-year-old acute breathlessness. They asked for a CTPA. Over to you. This is a CTPA.
Okay, I am presented with axial cuts, CTPA mediastinal window. I would like to scroll down. I can see that there is a filling defect seen here in the right main bronchus.
Yeah, don't worry about it. There is just a very bronchial thickening.
Okay.
So let me tell you, because of time factor, that there is no PE. So what will you do? But you can scroll. You can scroll it.
Okay, I can see there's bilateral pleural effusion, and I would like, in my routine practice, I would like to check also the lung window. And I will go down to the abdominal cuts. Okay, I can't see any abnormality in the upper abdominal cuts, so I would like to check in the lung windows. Yeah, in the lung window, I can see that there is bilateral ground glassing with interstitial thickening. It's more central, very vascular, perihilar. Was there's some nodular opacity seen in the right middle lobe. Yeah, okay, so I'm thinking this is interstitial, sort of interstitial lung disease with ground deglassing, and I would like to review the bone window and the mediastinal window also too.
Just 1 second.
Okay.
The bone window is with you.
Okay, thank you. In the bone window, I can see there is some lucent lesions seen in the right humeral head. I will go further. And yes, and some lucency in the sternum as well. With increased bone density. I think there's extensive bone abnormality going there, like extensive sclerotic metastasis. This is a male patient?
Yeah.
Yeah, okay, so in a male patient, I'm worried about if there is, I would like to ask if there is any urinary symptoms or background history of prostatic cancer.
The patient is 44 and there is no history of prostatic cancer.
Okay, 44.
So can you just conclude the case?
Okay, can I check in sagittal view?
Okay, I'll give you a sagittal view. Here you are. Which window do you want?
Bone window, please. Okay, in the bone window, I would like. Yeah, I can see that there is extensive sclerosis with bone heterogeneous pattern with some lytic areas. I'm thinking that this might be extensive bone metastasis. I would like to do, and there's some here in the vertebral bodies. I can see that there is a central decrease in the height of the central in the center of the vertebrae. So I'm suspecting this is.
Madam, just conclude the case. Give me the conclusion.
So I'm thinking this is extensive bone metastasis.
Thank you. Thank you. Chat, what do you think it is? Sickle cell. So this is sickle cell disease with acute chest syndrome. Actually, I showed you not this case, but similar case last session. Unusual presentation of a normal sickle cell disease manifests its multi-system ischemia and infarction. So please remember that sickle cell, this is a slide which tells the pathophysiology, which I'll skip, but the point is that don't forget that usually we consider sickle cell in MSK, but sickle cell actually can involve anything. Last time I also showed you a brain case with fat embolism, etc. So look at this. And most of the people who die of sickle cell, by the way, unfortunately, this is the cause actually. uh, Pulmonary causes, acute chest syndrome, which is non-specific. Patient can have emboli, can have infarction, can have pneumonia, etc. But they will come with these kind of findings. So in sickle cell, there is no single underlying etiology in acute chest syndrome, but a variety of infection and non-infection cause. What are the causes? Pneumonia, pulmonary infarction, fat embolism, rib or sternal infarction causing atelectasis because of splinting. So the patient finds it so painful, cannot tolerate this. So this was sickle cell. Now, again, though windows were asked, so that was I was happy because of that by the candidate, and various sequences were also asked, but a bit of fine touch. So CTPA component was normal, and then there is bilateral, non-specific patchy consolidation, bilateral, right? And but one finding is that this is what I call a infarction of the spleen in evolution. If you see here, already the spleen is developing a bit of calcification. It is smaller. Look at the density. By the way, I'm showing you a bone density right now. So this spleen should have been picked up. This spleen was an exam spleen, and it is also visible here. If you see, look at the enhancement, and it is different than usual enhancement. So even this should have triggered a, and then as far as diffuse abnormality, thing from Mumbai, everything. Now the candidate asks that head-shaped vertebra were picked up, but the inference could not be made. So I thought that once you have picked that up, you will say it is sickle cell, but you did not. I've got a X-ray chest which was done about 3 days before the CTPA. And on X-ray, so this is also exam case, classical exam. We have showed you these kinds of cases many times. This is same patient, and here you see, look at this humerus and look at this humerus, and that will trigger. And when you see this and you change the window, etc., you will even see that so this per se is an exam case. The spleen is not as calcified as visible, but at times you will see calcified spleen. Okay. Well done, except for the inference, you picked it up. So candidate 4, this is fever with jaundice, 67 female.
Sorry, doctor, what is the history again?
67 female, he presents with fever with jaundice.
Fever with jaundice, okay. This is an CT abdomen and pelvis. Sorry.
Is it,
Sorry, I will request remote control. Sorry.
let me mute this one first.
Okay. Yeah, can I scroll? Yes, this is axial CT abdomen pelvis portovenous phase. I can see that there is multiple branching hypodensities seen within the liver, which I think this is intrabiliary radical dilatation, and there is the gallbladder is seen enlarged with calculi seen inside. The CBD also is dilated with calculus seen inside the CBD. Hello? Hello, am I audible, doctor?
Yes, you are audible. We can hear you. Madam, are you speaking now? Candidate 4, can you hear me?
Yes, doctor, I can hear you, but I'm facing a problem with the scrolling now.
Leave it, I'll scroll for you. Just leave it.
Okay, thank you.
So I told you just to concentrate on the hepatobiliary system, pancreas, and the hepatobiliary system. I'm going superiorly. I'll come back.
Okay. So I can see that the intrahepatic biliary radicals are dilated with stones inside some of the central biliary radicals, and there is a gallbladder stones as well. The CBD also is seen dilated with a stone seen distally.
The dilated CBD.
Sorry, no dilated CBD?
No, you tell me. You've said there is a dilated CBD.
Yes. Can you just scroll down? This I can see there's a stone here. Sorry, but there's a
CBD,
stone here.
but is the CBD dilated?
Not really.
Do you see the CBD?
I will check it also in the coronal window after that. Okay. So yes, this is a dilated intrahepatic biliary radicals with gallbladder stones and suspected obstructing stone in the CBD. The pancreas appear normal with no peripancreatic fat stranding. So there is no evidence of acute pancreatitis. So can I please check the coronal view?
So I've gone clearly and I'll come back.
Okay. Yes, this. There's multiple linear stones seen, but I can't see the CBD dilated. So I'm suspecting this might be.
Just give me your conclusion.
I'm suspecting this might be a type 2 of choledochal cysts, dilated intrahepatic biliary radicals with gallbladder stones.
Chat in the chat. Hilar cholangio is, somebody has said hilar cholangio.
Yeah, the gallbladder looks abnormal for me as well, but I'm not really sure about it.
So I'm showing you a T2 of
This
the,
is T2 MRI, axial cuts T2 MRI. This is also dilated intrahepatic biliary radicals with some with a stone seen inside the intrahepatic biliary radicals. This is maybe the oriental cholangitis because of the intrahepatic biliary stones.
okay, thank you.
Thank you.
This is gallbladder carcinoma with biliary tree invasion. Now, I'm teaching you in a totally different perspective this case because when you do a cholangiogram, look at the anatomy. This is the left hepatic duct. This is the right common hepatic duct. This is the confluence of duct. This is the common hepatic duct. And the CVD, of course, will be distal to where the cystic duct is. This is the CVD. Now, if there is obstruction at this level, we call it the hilar level. This here, there will be three differentials. One is cholangiocarcinoma, portohepatic metastasis, which secondary invasion, and gallbladder carcinoma. Please remember that gallbladder carcinoma will be at the same level. If the obstruction is at the mid CBD level, then the top differential will be cholangiocarcinoma and pancreatic carcinoma. And of course, if it is in the distal CBD, then it can be pancreatic carcinoma, cholangiocarcinoma, or carcinoma of ampulla of water or duodenal carcinoma. Benign structures at post-surgical will be at common hepatic duct level, and chronic pancreatitis will be at distal level. So uh, here the same thing on MRCP. So this is the confluence, left hepatic duct, right hepatic duct, confluence of duct. This territory is the learning point in this case, cholangiocarcinoma, GB carcinoma, portohepatis metastasis. This case has got status post cholecystectomy, and we can see a stricture here that is classical Klatskin type of territory, Klatskin tumor, hilar cholangiocarcinoma. This is a PTC. We can see that the left hepatic duct, right hepatic duct is dilated. On the other hand, look at this MRCP, where this is the pancreatic duct, this is obstructed here, this is the CBD, the mid CBD is obstructed, so there must be something sitting in this area. This is a mid CBD, and this is a pancreatic carcinoma. By the way, a cholangiocarcinoma can also cause this because it can invade the pancreas. This is double duct sign. This is still a double duct sign, but here it is at the ampulla. So something is there, and the differential, so the CBD is dilated, pancreatic duct is dilated, and this can be a cholangio, a pancreatic, or it can be carcinoma, ampulla of water, or a duodenal carcinoma. Just to make a point that this is another case of CT of gallbladder carcinoma. The gallbladder actually is completely replaced by this mass, And with that, what you find is that there is intrahepatic duct dilatation. The CVD is not visualized and means that there is obstruction somewhere here at the hilar level. This is an ERCP of the same patient, and you can see a stricture at just distal to the hilar. And this is the left hepatic duct, which is carcinoma gallbladder. This case was just, and these kinds of cases do come in the exam where the, slightly unusual appearance case is very simple, but the examiners want to see that how do you infer it. And here, what what are the findings is that left hepatic ducts are dilated, we can see stones inside, which is what does it mean? If we see here, this is the gallbladder. The gallbladder is replaced by a mass. If you look carefully, there is a bit of enhancement inside. And there are stones there, and the stones are sitting here also. Of course, that is a red herring. There are multiple stones sitting in the distal CBD, but proximal to this, it is that Klatskin tumor type of appearance where the common hepatic duct is completely, encased and crossed by the mass. This is carcinoma gallbladder, simple as that. And on this MR, we can see the stones are inside, but actually, if you look carefully on this T2-weighted sequence, we can see tumor actually has gone, tumor has also gone in because this is the gallbladder, which is completely replaced. And you can see this element here, which is the solid component. And then you can see that how it is compressing the common hepatic duct more distally. As I'm pointing out here, you can see the CBD. Now, this is the head of the pancreas. Here it is visible, and then you see those chain of stones. So this was just a busy type of a scan, which do come in the exam, where you can, the fine touch of findings is what has been checked in this case. And the tumor has gone into, from the gallbladder, it has gone into the biliary system, and we can see it there. Okay, last case of the day. So this is a 14-year-old, 2-week history of lump under in right side of mandible, under the right side of mandible since 2 weeks. Last case of the day.
Okay. Your request to control. This is MRI T2 axial cuts, where I can see there's bilocular hyperintense signal seen in the floor of the right floor of the mouse. It extended down. So I can see it extended down. I will go up again to check the brain.
Just concentrate.
Okay, concentrate on this. Concentrating on this finding, I would like to check it in the coronal cuts to see the extension.
You describe it for me.
Yes, this is high T2 signal. Lesion seen at the base of the right mandible, seen extended down to the neck. This is in the submandibular space.
Okay, madam. Where it is? What did you say?
This abnormality,
Yeah. Which space you talked about?
submandibular.
So I've given you a coronal.
Okay. Yeah, this is the abnormality. I can see it is loculated high signal seen within the submandibular region going up to the base of the tongue.
Okay. Just give me your diagnosis.
This cystic lesion seen abnormality in the submandibular gland. I'm not really sure, doctor.
Just okay. Thank you. You've got the diagnosis in the chat. So this is a diving ranula on the right side. Now, first of all, this is an important exam case. Many a times, this is the differential diagnosis is a cystic lesion in the submandibular space, and it has come in the exam many times. So it is very important, and I'll go through a bit of anatomy. This is the tongue, the oral cavity. Now, in the space, what we call concept, this is the mandible. Now, here is the sublingual gland sitting here. So we call it the sublingual space. This is the submandibular duct here. This blue one here is the submandibular space. And you should have a very clear-cut idea about anatomy, and only then you can diagnose uh, what it is. Now, this diagram will make anatomy very simple. Here, this is the mandible, and this is the sublingual gland. Look at this. This is the submandibular gland. Submandibular gland, this muscle here is a key landmark by the name of mylohyoid muscle. This is just like the pelvic levator ani muscle. It's just like it produces a diaphragm. So submandibular gland is sitting here, portion of it is sitting superior, but the key point is that the duct goes and so it opens under the tongue. So this is sublingual space, this is submandibular space. Look here, there are two tubercles here, superficial mental spine for origin of genioglossus muscle. So genioglossus muscle is the tongue muscle, right? Now, if you go to a coronal, now this coronal here, this is that landmark. This is the mylohyoid. So the sublingual gland is here, superficial to it, and inferior to it is the submandibular space. So this is the submandibular space, and this is that genioglossus muscle. Now, what happens is, basic concept is that in the sublingual gland, there can be retention cyst, which is a pseudocyst, and it will appear to you just like a fluid-containing structure with very thin, imperceptible walls. It will not enhance unless it is infected, and though infection is quite rare. So it stays there. So this is in the sublingual space. But what happens is that sometimes they burst. When they burst open, from the sublingual space, they go to the submandibular space. So they are here, and then they extend into the submandibular space. They can actually, sometimes what happens is that there can be defects in the mylohyoid muscle, and it can go through it, or it can go like this, over as if it is going like a waterfall. So once it goes into the submandibular space, it will appear as a lump under the mandible, a cystic space under the mandible. So this is known as a simple ranula, a retention cyst in the sublingual space. When it goes into the submandibular space, we call it a diving ranula or a plunging ranula. If you see, this is a classical exam case. This is a classical exam case which I'm showing you on this slide, where portion of the ranula is sitting here in the sublingual space, but main one is sitting in the submandibular space. On the contralateral side, this is the submandibular gland. This sign is known as a tail sign, T-A-I-L, tail sign, which tells you that it was sitting here and then it has gone down, it has burst into the submandibular space. So this is a plunging ranula or a diving ranula. This picture also tells you the same thing. Here is another example of a ranula which goes from the sublingual to the submandibular space. In your book, there is a differential diagnosis, and the differential diagnosis is submandibular space lesions. Submandibular space lesions. The word lesion, because of space, it contains cystic lesions as well as solid lesions. So diving ranula is given there. Simple ranula of sublingual space ruptures into sublingual through a myelohyoid defect form a thin wall comet-shaped pseudocyst. But this differential diagnosis is extremely important for the exam, and this has come in the exam quite a few times. Submandibular space cystic mass. So we have disregarded the solid ones in this one. Diving ranula is one. Second branchial cleft cyst, submandibular abscess secondary to infection. Necrotic node is extremely important. Lymphangioma, dermoid, and epidermoid. Now, if you see here, this is a classical uh, sub second branchial cleft cyst. The classical location is, this is the sternocleidomastoid. So this is the sternocleidomastoid muscle. This is the submandibular gland. In between the two is a cyst, and this is a classical location of second branchial cleft cyst. On the other hand, so this was a simple one, and the second branchial cleft cyst can also infect. This is an infected one, 11-year-old, and it shows enhancement. And beware of this one. This is a cystic lymph node, which is a malignant necrotic lymph node. And the key thing is that on MR, there is a bit of necrosis, and look at internal septations, etc. So, our case is actually diving ranula. And once you know this anatomy, it becomes so easy to diagnose it. So axial, on axial, this is it. Now this is the tongue, and this is of course the mandible. You can see that there is a cystic linear structure. It go the other way around, and it is going posteriorly. This is the submandibular gland. This is the submandibular gland. Here it is plunging down. It goes down, and if you see a coronal, now it becomes very simple. So if you see here, this is that mylohyoid. This is the mylohyoid. This is the mylohyoid. So if I show you in the exam, I can even ask you which muscle is this, which muscle is this, just like the levator ani, right? And you see it has going through a defect. In this case, it is going through the defect. You remember, it can go through a defect. It can go like a waterfall also. So here, this was the sublingual component, and it is going, you can actually see this defect, and it has gone. Now, this is the mylohyoid, this is the defect, and it has gone, it has plunged down, and now you can see the capsule has been attached here. So the patient has presented with a swelling of the neck on right side. So this is a diving ranula. You can also see the same thing here on a sagittal. So this is where it is visible. So this is the submandibular gland. This is it, and the main connection is with the sublingual space. So, okay, thank you very much. That is all for today. So, it's a very challenging format to teach as well as to show you cases, but and I'm conscious of people who are from overseas because it must be 2 o'clock, 3 o'clock in the morning. Having said that, uh, having said that, uh, I'm sure the yield of these sessions are good. So we will continue. Next week, again, it will be my session, and I will, I think, do a potpourri once again.